Diseases of pericardium. The normal pericardial sac contains about 50 ml of fluid that is similar to lymph, and this fluid lubricates the surface of the heart. The pericardium is the distension of the heart and contributes to the hemodynamic interdependence of the ventricles and acts as a barrier to infection. There are some cases in which the pericardium is absent. However, this does not significantly cause functional limitations. Acute pericarditis. This is an acute inflammatory process affecting the pericardium. It may coexist with myocarditis and causing myopericarditis. The causes include viral, bacterial, tuberculosis, systemic lupus erythematosus, rheumatic fever, other such as post-myocardial infarction, uremia, malignancy, and the trauma. The typical presentation is with chest pain that is retrosternal and radiates to the shoulder and neck. Typically said it is radiated to the trapezius muscle. It is typically aggravated by deep breathing, movement, and a change of position, and the exercise and the swallowing. There is a low-grade fever that is common. On examination, you may detect a pericardial friction rub on auscultation, which is a high-pitched superficial scratching or crunching noise produced by the movement of the inflamed pericardium and is diagnostic of pericarditis. It is usually heard in systole, but may be audible in diastole and frequently has a to and fro quality. We will concentrate on investigations on Ecg and Echo. Other investigations include elevation of the inflammatory markers. The Ecg shows a concave up ST elevation over the affected area, and which may be widespread, so it is described as widespread or global ST elevation. And there is PR interval depression, which is very specific indicator of acute pericarditis. Later, there may be T-wave inversion, particularly if there is a degree of myocarditis. And T-wave inversion usually does not occur until the ST segment has returned back to baseline. Echocardiography may be normal or may reveal pericardial effusion, in which case the regular echocardiographic monitoring is recommended. This is the Ecg of a patient with pericarditis showing widespread ST elevation and PR depression. In AVR, it is the reverse. You see ST segment depression with PR interval elevation. The ST elevation is concave up. Treatment. The pain usually responds to aspirin, 600 milligram, 6 times daily. But a more potent anti-inflammatory agent, such as indomethacin, 50 milligram, 3 times daily, may be required. Sometimes we may give ibuprofen also instead of indomethacin or instead of aspirin. Colchicine or glucocorticoid can also suppress symptoms, but there is no evidence that they accelerate the cure. And glucocorticoids can cause increased relapse rate. In viral pericarditis, recovery usually occurs in a few days or weeks, but there may be recurrences causing a chronic relapsing pericarditis. Purulent pericarditis, which is caused by bacterial infection, requires antimicrobial therapy, and sometimes pericardiocentesis and even surgical drainage may be required. Pericardial effusion. It is the accumulation of a fluid in the pericardial sac, and it often accompanies pericarditis. The causes are similar to pericarditis. يعني من الامتحان إذا سألته على causes of pericardial effusion هي ترجعون نفسها لل causes of acute pericarditis. All forms of pericarditis may produce pericardial effusion that depends on the etiology. This may be fibrinous, serous, hemorrhagic, or purulent. Fibrinous exudate may eventually lead to varying degrees of adhesion formation, يعني صار عندنا التصاقات. Serous pericarditis often produces a large effusion of turbid, straw-colored fluid with a high protein content. Hemorrhagic effusion is often due to a malignant disease, particularly carcinoma of the breast, bronchus, and lymphoma. يعني spread from the adjacent tissue usually. Purulent pericarditis is a rare Purulent pericarditis is rare and may occur as a complication of sepsis by direct spread from an intrathoracic infection or from a penetrating injury. Cardiac tamponade. Here where the pericardial effusion causing hemodynamic consequences and causing acute heart failure. It is due to the compression of the heart as a result of a large pericardial effusion. It may complicate any form of pericarditis, but can be caused by malignant disease, by blood in the pericardial sac following trauma, or by rupture of free wall of the myocardium following myocardial infarction. The rate of accumulation of a fluid is very important. Clinical features of cardiac tamponade: dyspnea, collapse, tachycardia, hypotension, gross elevation of JVP, soft heart sound with an early third heart sound, pulsus paradoxus, a large fall in the blood pressure during inspiration when the pulse may be impalpable. عادة احنا during inspiration there is a fall, a physiological fall in the blood pressure. In cardiac tamponade, this normal physiology is aggravated, causing the phenomena of pulsus paradoxus. And this pulsus paradoxus, it is a misnomer. It is not a true paradox. It is just aggravation of the normal physiology. Davidson mentions Cosmal sign as also, which is a paradoxical rise in JVP during inspiration. However, it is more evident in constrictive pericarditis. Investigation for pericardial effusion and tamponade. Echocardiography shows the accumulation of fluid in the pericardial cavity and shows the tamponade physiology, such as the RV diastolic collapse, and it can confirm the diagnosis and helps to identify the optimum site for pericardiocentesis. The ECG may show features of the underlying disease, such as features of pericarditis or feature of MI. When there is a large pericardial effusion, the ECG are small and low voltage, and there may be electrical alternance, defined as a changing axis with alternate beat or even changing voltage. يعني شوية كبيرة وراها شوية صغيرة وهكذا. أو تبدل الأكسس يعني مرة فوق مرة جوا. This is caused by the heart swinging from the side to side in the pericardial fluid. This is a picture showing a chest X-ray with a globular heart in patient with pericardial effusion. You can see that the heart is large, but you cannot see the hyla clearly. This is an ECG showing the low voltage ECG, small complexes with electrical alternance. You can see that this is upward and this is downward, this is upward and this is downward, and so forth. This is called an electrical alternance. Investigations. Aspiration of a fluid, which may be a part of therapeutic pericardiocentesis. يعني احنا قررنا للمريض انه لازم نسحب هذا الفلويد. When you aspirate this fluid for a therapy purpose, Some of this sample will be sent for microbiological, biochemical, or cytological studies. But sometimes you may do this only for diagnostic purpose. This is a subcostal short axis view showing the accumulation of fluid, pericardial effusion, and this is also a subcostal view, a four-chamber subcostal view showing pericardial effusion with our right ventricular collapse. This is the right ventricle, and this is the collapse. This is a movie showing the swinging of the heart with the RV collapse. This is a large pericardial effusion, and this is the heart, and you can see how the heart swings. This is echo finding also of pericardial effusion. You can see, of cardiac tamponade. You can see a right-sided chamber collapse, and right ventricle or right atrium. This is a right atrial collapse, and this is a right ventricular collapse, and this is an MO showing right ventricular collapse. And you can see the variation of the E-wave velocity, any variation of the flow through the mitral valve. This is a surrogate for a Doppler surrogate for pulsus paradoxus. You can see a plethora of the inferior vena cava that is dilated and non-compressible. Management of large pericardial effusion and tamponade. Patients with large pericardial effusion that are causing hemodynamic compromise or cardiac tamponade should undergo aspiration of the effusion, and cardiac tamponade is an emergency. This involves inserting the needle under echocardiographic or fluoroscopic guidance, medial to the cardiac apex or below the xiphoid process, and directed upward towards the left shoulder. طبعا الروت راح يعتمد على الاكسبيرينس of the operator، ايش قد الاوبريتور متعلم على which side، and the shape and contour of the patient, physique of the patient, and the position of the effusion. مرات احنا ما نقدر نسحب من جهة معينة لأنه occultation. Pericardial drain may be placed to provide symptomatic relief. يعني نخلي الدرين، نخلي الكاثيتر، نسميها pictal catheter، نخليها inside the pericardial sac, and we will aspirate continuously if there is reaccumulation until there is no reaccumulation of fluid. Management of large pericardial effusion also has some complications in pericardiocentesis. This includes arrhythmias, damage to the coronary artery, bleeding, and this bleeding can exacerbate the tamponade. It is usually the result of the right ventricular damage during aspiration، لأن احنا right ventricle راح يكون in our root, but may be accidentally damaged by our needle. Damage to the coronary artery also can cause myocardial infarction, and this coronary artery will be damaged. This damage to the coronary artery will obstruct the flow to the myocardium. When tamponade is due to cardiac rupture or aortic dissection, the pericardial aspiration may precipitate further potentially fatal bleeding, and in this situation emergency surgery is the treatment of choice. ولذلك دائما لما يصير عندنا pericardial aspiration, aortic dissection or cardiac rupture, we send the patient to surgery، لأنه the leak of fluid from the myocardium or from the aorta to the pericardial sac is stopped by the pressure inside the pericardial fluid. When you do aspiration, you will relieve this pressure, you will cause more bleeding, you will cause more blood to exit from the heart and from the aorta. In certain cases, there is viscous, loculated, or recurrent effusion, and this may require formal surgical drainage. This is a picture of a patient of the procedure of pericardiocentesis. This is the left sternum, or this is the the left costal cartilage, and we will. The needle is directed to the left shoulder in this angle, just under the xiphoid, the xiphisternum, and this is how we pass a wire, and then we pass a catheter to the pericardial sac under fluoroscopic guidance, and this procedure may also be done under echocardiographic guidance. Tuberculous pericarditis can complicate pulmonary tuberculosis, but may also be the first manifestation of the infection. The condition typically presents with a chronic malaise, weight loss, and low-grade fever. An effusion usually develops, and the pericardium may become thick and unyielding, leading to pericardial constriction or tamponade. Yani when we try to aspirate, sometimes the fluid cannot be aspirated because it is thick. You can sometimes find an associated pleural effusion. The diagnosis can be confirmed by aspiration of the fluid and direct examination or culture for tuberculous bacilli, and also for sending this fluid for PCR, or sending for adenosine deaminase, and the high level of adenosine deaminase indicates the pericardial effusion is due to tuberculosis. The treatment requires specific anti-tuberculous chemotherapy, and in addition, you need a 3-month course of prednisolone with an initial dose of 60 milligram and tapering down rapidly, and this improves the outcome. Chronic constrictive pericarditis is due to the progressive thickening and fibrosis and calcification of the pericardium, resulting in a hard pericardium that is similar to a stone. The heart becomes encased by a solid shell and cannot fill properly, so here the diastolic function of the heart is impaired, and this calcification may also be extending to the myocardium, causing impaired myocardial contraction and therefore impairing the systolic function of the heart. The condition often follows an attack of tuberculous pericarditis, but can also complicate hemopericardium and viral pericarditis, rheumatoid pericarditis, and purulent pericarditis. It is often impossible to identify the original insult. The clinical feature of constrictive pericarditis include fatigue, rapid low volume pulse, elevated JVP with a rapid Y descent, low early third heart sound or pericardial knock, cosmal sign, hepatomegaly, ascites, peripheral edema, and pulsus paradoxus. The symptoms and signs of systemic venous congestions are the hallmark of constrictive pericarditis. AF is common, and there is often dramatic ascites and hepatomegaly. Breathlessness is not a prominent symptom because the lungs are seldomly congested, and the condition sometimes overlooked, but should be suspected in any patient with unexplained right-sided heart failure and a small heart. Yani, you find patient systemic congestion and you find a right-sided failure, features of right-sided failure, but when you find small heart on echocardiography, there is no cardiomegaly. This condition is often difficult to distinguish from restrictive cardiomyopathy, and in such cases we may need echo, Doppler complex studies, and even catheterization. There are many features between them that are in common, and there are others that are differentiating between constrictive pericarditis and restrictive cardiomyopathy. This is a difficult subject, and I have not entered into the details. Chest X-ray may show pericardial calcification. Echocardiography can help to establish the diagnosis, showing the features of ventricular interdependence. CT scan also can show the pericardial calcification. This is a chest X-ray lateral view showing calcification in the pericardium, and this is a CT also showing the pericardial calcification. This figure shows physiology of ventricular interdependence. This is septal bounce. So you see during expiration, the septum bulges towards the LV, and during expiration, the septum bulges towards the RV. The resulting diastolic heart failure is treated by loop diuretics, aldosterone antagonist, and spironolactone, and sometimes you need surgical resection of the diseased pericardium that can, which leads to dramatic improvement, but this carries high morbidity with disappointing results in up to 50% of the cases. Thank you very much.